This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. All right, welcome everybody to another episode of PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in Pittsburgh, Pennsylvania, at the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since October of 2016, going over the content specifications for pediatric hospital medicine, as it was a new subspecialty then. And we've been trying to come to you every 4 to 6 weeks with a new topic to discuss. So I'm going to be honest with you all. This one is something I've been thinking about doing for a while, and we're going to just dive right in. So since the murder of George Floyd, I have been struggling with strong emotions of sadness, frustration, anger, and a desire to further and more deeply understand racism in America. A topic which, honestly, stupidly, I thought I understood or at least had a handle on. And I know I'm not alone. It's evident and clear there needs to be changes for there to be real equity. And I thought a podcast would be beneficial to at least have a conversation about racism in medicine. Now, to be frank, as a white male, I know I'm not the person to steer this discussion. I want to listen and learn. To that extent, our expert guests today were kind enough to give up their time to lead us in this discussion on racism in medicine in America. Our focus will be critical race theory and its application to medicine. So without further ado, I'd like to introduce our first guest. We have two. I'd like to introduce Dr. Shaquita Bell. Born and raised in Minnesota, Dr. Bell is Cherokee on her mother's side and African American on her father's side. She completed medical school at the University of Minnesota in 2006. Dr. Bell then went on to pediatric residency at the University of Washington, which she completed in 2009. In 2010, she remained at Seattle Children's, completing a chief residency year, becoming the first Native American chief resident at Seattle Children's. Dr. Bell is currently a pediatrician at the Community Health Center Odessa Brown. She is the site coordinator for pediatric residents. She is a clinical associate professor at Seattle Children's and the University of Washington in the Division of General Pediatrics. Additionally, she's the medical director of the Center for Diversity and Health Equity at Seattle Children's Hospital. She is the chair for the American Academy of Pediatrics Committee on Native American Child Health. Dr. Bell also runs the trafficking work group at Seattle Children's Hospital. So, Dr. Bell, let me first say welcome to you. Thank you for joining us.
Thank you, Tony. I'm really excited to be here.
I would also like to introduce our second guest, Professor Edwin Lindo. Professor Lindo received his Bachelor of Science degree in Business Administration, International Relations from the University of the Pacific, and his Doctor of Jurisprudence degree from the University of Washington School of Law, where it currently holds an affiliate faculty. His teaching and scholarship focuses on critical race theory, history of racialized medicine, and the application of critical pedagogy in medical education. Honors include the Hero Award recipient in San Francisco Human Rights Commission in 2016, the Community Hero Award recipient, San Francisco Lit Quake Festival. At UW, or University of Washington Medical School, he received the Dr. Martin Luther King Jr. Distinguished Service Award. He is faculty for the Department of Family Medicine at the University of Washington, and also the Associate Director for the Center of Leadership and Innovation in Medical Education. Professor Lindo, thank you for joining us.
Thank you, sir. Thank you so much for having me, Tony. I appreciate you inviting us on and letting us have this important conversation.
All of the guests on the podcast today, Professor Lindo, Dr. Bell, and myself, have nothing to disclose. Well, without further ado, I will be quiet here and let you all take it away.
Yeah, great. Well, I just want to tell your listeners that you're in for a treat having Dr. Bell, who has been doing this work for quite some time. And so I'm grateful to share the stage with her. And my goal here is to really dig into the nuance and the importance of why we must be talking about structural institutional, interpersonal, and really all forms of racism throughout medicine. Right? My specialty is my expertise in research and scholarship surrounds itself around critical race theory, particularly critical race theory as it applies to medicine. For many of you, hearing critical race theory may be a first. You may be thinking, what is critical race theory? At its core, critical race theory is a framework that allows us to look at systems and critique them through a race-conscious lens to understand how systems of power and oppression have lent and really pushed the inequities that we see today throughout a number of different racial groups and communities. So in its nuts and bolts, what does that mean? Well, it means that, number one, critical race theory tenet number one tells us that race is a social political construct, that it was created by people and society adopting it for the purposes of creating racial hierarchy and racial taxonomies. And that was started by physicians. And so I want to be clear that medicine, biomedical history, biomedical research has a deeply rooted effect on how we talk about race and the racism that has manifested in the way we see it today. It was Johann Blumenbach who laid out different forms of categories for people of different parts of the world. The racial colors that we use today as a descriptor of differentiating different people, and not as a descriptor of just saying, oh, these folks look different. It was intentionally used as a way of creating, again, a hierarchy of, there are some groups that are quote unquote better and other groups that aren't as good. And the way he described them is Europeans being dressed in clothes and governed by laws, but when talking about Native Americans, discussing them as savages who didn't have laws and were governed by customs and traditions. Right? That's not an accident, but medicine had a huge part in that. And you fast forward to today, the first tenet of critical race theory, again, that race is a social political construct, helps inform how we look at medicine. Because it was made by someone for the purposes of their benefit, we then have to look at when we see race in our current biomedical research, in our studies, even in our clinical guidelines, we have to critique it. And that's another tenet of critical race theory, is we have to take a very critical approach to understanding the racial powers and social powers at play that affect the outcomes of people's health and the health of communities. I'll give a brief example. You have the eGFR, right? The glomerular filtration rate equation that tells for many pediatricians and many primary care docs, how well is the kidney functioning? Well, for many, you may not be aware, but when you put that lab out to get tested and it comes back, there is a number that includes an African American number, a Black number. Why is that? Why is race a social political construct, not based in biology, used as a mechanism to determine clinical and diagnostic outcomes? It's because we poorly understand how race actually works. There are many people, and there may be some who are listening now, that believe that race is a biological factor, that race informs how our biology manifests itself. And the truth is that's not rooted in science. The geneticists have told us, if I give my genome to a geneticist and say, please tell me what race I am, they would respond and say, Edwin, I can't tell you what race you are. There is no race gene. I may be able to triangulate which part of the world geographically your ancestors are from, but that doesn't tell me what race you are. To further the point, if you go to different countries throughout the world, race is defined differently. Here in the United States, we have African American, Black, you have Native American, Alaska Native, you have Hispanic or Latino, you have Asian, you have white. But if you go to South Africa, it is white, colored, or Black. So if we're doing rigorous scientific research in the United States based on racial categories that were made up, but then say that this is now biological fact, it can't be, because how does it then become translated to the racial categories of different people across the world? The eGFR is a great example. That racial coefficient has been critiqued, and at the University of Washington, we've actually removed it now. because we said there is no place in these diagnostic tools for race to be involved because the science doesn't support that. So we use now the CKD epi without race, and we're now trying to figure out ways, how do we get even more precise with identifying if the EGFR is to measure creatinine serum, which is one of the equations, and to measure renal function, then let's find better ways to measure renal function without using the proxy of race. And that's what we're going towards, and that's what we're doing, which is unbelievable, but it took many years to get to that point. I think there's a number of other examples that you may have heard about hypertension, and that there's certain prescriptive drugs that we offer depending on what race an individual is. Well, if we dig into that science, the truth is that it doesn't hold up, because if you give one person channel blockers and another one ACE inhibitors, they suggest that there's inherent differences in the responses. But if you give both of them diuretics as a secondary, that change or that delta no longer exists. So it doesn't mean it's racial difference. It means that there's a different response based on the individuals, and we don't actually know the reason. But it's not racial because race is not genetic. And I keep hammering that point, and you say, Edwin, you've said that already. I keep saying it because the number of times I talk about this and the number of times my colleagues who are physicians come up to me and say, Edwin, I hear you, but I do research on name the research, and there is clear differences on racial lines. And I'll say, interesting. So how about, do you know why there's differences on racial lines? No, I don't know the reason. I said, okay, so then it's clearly not race, because you can't hold for race. There's nothing biological about race that you can hold for and say, let me study this particular thing. So I don't want to belabor the point, but that's an important one of critical race theory. Then being critical, a third tenet that I want to bring up is also including the narratives and the stories and the experiences of communities that historically are marginalized. I bring that up because the data shows us that when Black women come to the ER, when they come to their provider and say, my chest hurts, they are less likely to be heard, and there's less follow-up versus a white woman that says the same thing. Now, I want to make an interesting point. Many people say, well, Edwin, I thought you said race wasn't important. So why are you telling this story about Black women versus white women? No, race is important for us to understand how people who are of different races have to maneuver the world differently and how the world treats them differently. Because our biology does respond to the external influences, without a doubt. Racism is a huge part of the external influences that dictate how people move throughout society. But when we listen to these individuals and to these communities, we can actually provide the care that they deserve. And so, simply put, when Black women come into the clinic and say, my chest hurt, let's not suggest that, oh, well, they don't feel pain, or I'm not sure about that, or, it doesn't seem like something I've ever seen before. Well, maybe because we aren't listening and we're not actually paying attention. And the last point I'll make about this is the reason we don't listen is deeply rooted in the history. And that's the fourth part of critical race theory, is we have to understand the history of things to better know what the current conditions are. So if we look at a study done in 2016 at the University of Virginia School of Medicine, this survey asked 400 medical students, do you believe one of these three biologically false statements? One, do you believe that Black people's blood coagulates differently than white folks? Do you believe that their epidermis or their skin is thicker than white folks? Or three, do you believe that Black people have a higher threshold of pain? And disastrously and scarily, 50% of those medical students in 2016 believed at least one of those things. And what the study showed us was, if you believed one of those things, your care plan would be different versus someone who did not believe one of those things for a Black patient who had pain. And so if you were a Black patient, you would get better care if someone did not believe one of those biologically false things. And that's an important note to carry, because it's not in our curriculum. It's not even in the hidden curriculum. It's in the upbringing of how people see the world as people of different races being biologically different, which is a very clear discussion of what happens in policing. And I won't get deep into it, but policing is a product of how we look at people differently. And you can look at the the psychology of criminology, but they suggest that Black people have a propensity for crime. You now start pathologizing Black folks as criminals as though it's somehow a defect of their genetic makeup. Right? They're inextricably bound, and I think critical race theory is a great lens and tool to explore it, deconstruct it, and address it.
So as physicians, we spend our careers saving lives. We find the root causes of disease and approach things with a public health lens. Thus, racism is our job. We can see the effects of racism in media and academic studies, everything from infant mortality rates, pain treatment outcomes that Edwin just mentioned, and even hospital-acquired infection rates. Since these results cannot be explained by a biologic factor, i.e., Professor Lindo's articulating the social political construct that is race over and over again, as a scientist, we must then approach these from a root cause, which is ultimately racism. So hopefully we have convinced you that this is your role as a physician. And then now you might ask, what can you do? And I think we are all being asked that right now, and a lot of people are wondering that with the current climate. And there really are a lot of resources. I don't mean to overstate when people say you need to educate yourself, but you need to educate yourself. You need to read books, you need to listen to podcasts, and really listen to what's going on. But you also can just look at academic research that's already been done. If you search in any database terms like disparities, inequities, you will find loads and loads of previous papers that have been done. If you take that information and take it to the work that you do, then you can start to see what meaning this might have in your own work. So what are you already measuring? Where might you find racism impacting the outcomes for the kids that you care for? And what would you like to know more about? Let's take an example. Bronchiolitis. Your hospital probably has a bronchiolitis pathway or clinical standard work. What are the measurements? What are important outcomes in that pathway? Is it use of steroids? Is it use of oxygen? Is it suctioning? Is it length of admission? Is it likelihood of readmission? Take those measurements and look at them with the lens of inequity and racism. Where could racism be impacting those outcomes? And measure those differences. It doesn't mean that those differences are born out of people's races. It means that your institution is treating people in social groups differently. So it's a little bit of a flip of what Edwin Lindo was saying, in that instead of thinking of race as a driver of disease, I think of race as a driver of risk in the way people are treated in medical institutions. So that means that children in these social groups are at risk in your hospital. This is focusing on outcomes of care instead of focusing on the individual's response to care. It means then that you take those results and find your drivers, which will lie in racism, but it also tells you where those drivers are coming from. So you could look at, for instance, how those bronchiolitic patients are treated on different floors, in different units, with different groups, over night shift, during day shift, by resident teams, by hospitalist teams. You could try to find the drivers and start to approach those through that lens. We want to avoid, when doing this work, we want to avoid centering whiteness. So if you're going to measure those outcomes, we don't want the outcomes of white children with bronchiolitis to be your goal. What you want to pick is, what is your goal for bronchiolitis? Maybe it's no use of steroids. Maybe it's less than 2 days of admission. Maybe it's no readmissions within 1 week. Those should be your goals, not whatever the rate is for white children in the same cohort. So with all that said, I think it's important to take this work and bring it home to the work that you do, no matter what that looks like. We'll share a number of resources, including readings and articles that have already been done on the website for this podcast. And we welcome you to explore this journey at your own institution.
Can I ask a question?
Absolutely.
It's your show.
Yeah, that's fair. For those of you listening at home, Edwin has a podcast called The Praxis, Praxis. I have listened to all the episodes that are currently released, and I'm waiting for more to be released. And they are excellent. It's a podcast on the way I would describe it, and Edwin, feel free to correct me if I'm describing it wrong, but racism in medicine, with good interviews on people who know a lot about the topic and understanding it more. Does that sound right?
Yeah, that's right.
And when you talked about this topic there and here, I'd like to make sure I understand this point correctly. When you're looking at research, and if you see a breakdown by demographics, black children versus white children, and you see a difference, whether it's the hydrochlorothiazide or UTI, to use a pediatric example, you're not saying ignore that because it's not biological. If I'm understanding you right, you're saying if there is a difference, figure out if the reason for the difference, for whatever the difference is, if there's a point of that in racism in medicine or not equity in medicine. Is that not to think there's a biological example, but not also to ignore it either?
Yeah, so I think you hit it on the head, and I'll expand a bit on it. So when I usually give my talks and I teach, people say, "Well, Edwin, if you're telling me that race is so poor and is not a useful scientific tool, then we should just get rid of it, and we'll get rid of racism." And I laugh because that's funny, because that's not how it works. Uh, I'm actually saying, no, I don't want us to get rid of it. I want us to use it in the most precise way possible. And the way we do that is that we use race to understand the health inequities that exist. And you can only do that if you know the racial makeup of the population you're studying or of the data that we have. Imagine if we didn't have racial data for COVID-19, we wouldn't have realized that there was a disproportionate effect of transmission and mortality among Black communities and Indigenous communities. So race is incredibly important for us to understand the social and economic and political impacts of communities, but not the biological reality of their bodies. We can see how racism affects their biology, again, because it's the environment affecting it, but not to suggest, oh, well, I'll give this example. In the beginnings of COVID-19, Black folks had the lowest transmission rate of COVID-19. In Africa, they were the last. There are many countries in Africa that didn't have any cases of COVID-19. I could have pulled the data and said, look, Black people are immune to COVID-19. And people would have lost. They said, what do you mean, Edwin? This is a disease. It affects everyone. And I said, exactly. There is nothing different about the human beings being affected by COVID-19. However, what is different is that in the United States and different parts of the world, there are communities that have had to live in concentrated poverty. Here in Seattle, Washington, we have high levels of poverty in South King County, which is, for everyone who's listening, South King County were the only places that Black, brown, Asian, non-white people could live because legalized redlining existed in this city up until the mid 1970s. I have a colleague who showed me his grant deed, and he lives in northern part of Seattle, and it says you cannot sell this home to a Mongol, a Jew, or a Negro. There is no accident that poverty and racial poverty exist in concentrations in different parts of this country. I think it's true for Pittsburgh. It's true for so many metropolitan cities. But to hammer in the point even more, take a guess where the highest levels of respiratory disease exist. It's in those exact same neighborhoods. And I think that's true throughout the country. Take the point a bit further. Who has the highest risk of mortality from COVID-19? Those with respiratory disease. So now we see the legacy of racism that has a direct impact on a person's and individual's biology of survival. And all it was is because they were born a different melanated color. And that's sad. And I think medicine not only has a role in affecting that, it has a responsibility to get out and say, well, if these communities live in these neighborhoods with the highest rates of respiratory disease, that means I need to go do something, whether it's city council, talk to elected officials, go to the state capitol and say, you need to change the circumstance and the conditions of these communities because they're going to keep coming back to my clinic with asthma and many other forms of respiratory disease, and I can't cure it in my clinic. We have to cure it in the neighborhoods and the communities that they're in and make them much more healthier.
That's the entire approach of public health, right? We don't just put out the fire in our clinic. The idea is that we try to fight the fire on a community level. The other thing I'll add on is that There are two words that we've used a couple of times. One is disparity and one is inequity. And disparity is, by definition, just a difference. And inequity is when that disparity is unjust. So it pulls in justice. And that's why it's really important to talk about things in the true term. And if you are doing a scientific study, you might use the word disparity because you literally mean difference. But when you're doing this work on a population level, as a clinician, as a scientist, we want to think about these things as what is just and what is not just. And that's why I like the term inequity, because it really implies that this should not be happening. The other thing that we go between is equality and equity. A lot of people talk about equality, especially historically, because that was the civil rights movement of the 70s, was equal rights. And that was very good for that time. That was our understanding of what was wrong with our society. But much like how we have taken to the streets over these last 3 weeks, we are evolving our language around what is just and what is social justice. And we are moving from a point of asking for equality to asking for equity. And equity means that everyone gets what they need to be healthy. So if you are short, maybe you get the boxes that everybody sees behind the fence. Maybe if you are in a wheelchair, you get a wheelchair adapted ramp. Those are things that make things more equitable instead of just equal.
And the beauty of that, and I'll expand on Dr. Bell's point, is many folks will think, well, why are we focusing on some subset group on what their needs are? And the truth is, when we actually solve for the issues of those most affected, they inevitably help everyone else across the board. My partner, wife, Dr. Williams, in the speech at the Healthcare Workers March that Dr. Bell was at and spoke at, and said those ramps that help people who need access to get onto the sidewalk, they don't just help people who are in wheelchairs. They also help families that have strollers. They also help people who are pushing carts. So it actually helps everyone across the board. But it's because we're focusing on a solution for folks who need it most.
So I've kicked around the idea of not asking this question because it's an uncomfortable question for me to ask. But one of the things I've learned, specifically from watching a show called Pardon the Interruption with Michael Obama and Tony Kornheiser, is you have to ask the uncomfortable questions to have uncomfortable conversations. So what do you say to people who say it's more socioeconomic factors, such as living in the poor neighborhoods and the neighborhoods where there's more air pollution causing asthma, and not so much a racial factor, because poor white people have similar issues? What do you say to people who say that?
All right. Well, there's a few things I say, and I've been asked it quite a bit. And so I have a list of things that I think should be shared because it helps ground the conversation. Number one, no one here is trying to play the Impression Olympics, right? I'm not here to suggest that some group is more oppressed. We're talking about folks who need the fundamental basics to survive in society, right? We're saying you should be providing what you promised communities from the founding of this country. So that's number one. But number two is that if it were just socioeconomic, then socioeconomics would solve for the problem that Black men who graduate with a graduate degree have a lower life expectancy than white men who haven't graduated from high school. There would be an explanation for why there are nearly 3,000 premature deaths of Black folks in this country from underlying chronic illnesses. Sorry, not 3,000, 30,000. But there are 30,000 premature deaths due to chronic illnesses. There would be an explanation for why, all else being equal, Black folks are at risk of dying 2.5 times more at the hands of law enforcement than any other race. To follow that point, there would be an explanation why, for young Black men, dying at the hands of police is one of the leading causes of death, which should not be the case for anybody. So if it were solely socioeconomic, then the incredibly wealthy Black, brown, indigenous folks would come out and say, we solved the problem. Folks just need to make more money. And the more money you make, the better you'll be. Now, it's true. The more money you have, the more likely you have better access to healthcare, which will better your health overall. But in its foundational sense, racism has a direct effect on the way people are maneuvering and living the world. And there's another data point that tells us that Black men who have survived to live to the age of 50 carry levels of PTSD to that of those that fought in the Vietnam War, just from the racial fatigue of walking through the world, of microaggressions, blatant racism, and everything in between. I wish it was just socioeconomic, because that means we could have solved the problem a long time ago, because I don't like to have to do this work. I wish I didn't have to do this work. I wish we can say, look, let's give everyone a fundamental basic income and we're going to save lives. And that will save lives. It's just still some lives aren't going to be saved as equitably as others.
The other thing I often respond to that question with is, I recognize we have this human nature of like, what about me? Like it's a very human thing to say, especially if you're not in the center of whatever spotlight it is, to say, but what about me? And I think if I'm speaking to a physician or a colleague, I really fall back on the fact that public health means what about our community? And if you want to think about, you can always come up with a hypothetical what if, you can always think of an exception to a rule or an exception to a diagnosis or a prognosis. You always hear stories the doctor said they would never wake up or they'd never walk again. But we're not talking about the case studies. We're talking about the root cause analysis. We're talking about the double blind studies. We're talking about population level impacts and not individual stories. And so for me, I think of that argument as being based in racism and being based in the vein of our human nature to be selfish, a little bit selfish, and our human nature to not see racism as the construct that is all around us. I think of it as the matrix, really. Racism is the matrix. And we have for so many years equated that term with being bad. Like, I'm bad if I'm a racist, or saying that I did something racist makes me a bad person. And if we could separate the value that we assign it to and talk about it as a reality, as if it exists all around us at all times, then we start to take away that individual threat and we think more on a population level.
I was uncomfortable asking that question. I don't believe in that question, but I've heard it and I felt like it's something that we should discuss.
Yeah. Edwin and I have definitely heard it a million times.
Yeah, we've heard it a lot. Yeah, and the last thing I'll say on it is, and I describe it in the podcast, so for folks listening who haven't heard the podcast, I give the analogy of when you go to the airport and there is that sidewalk conveyor belt that you get on to help you get across to the next gate. And it's folks with privilege and power stepping on there, white folks stepping on there and putting their hands up and saying, but I'm not doing anything. I don't understand what the problem is. How is there racism when I know I'm not doing anything? And the truth is it's not just an individual act contributing to racism. We're talking about policies, law, education, clinical guidelines. At the current moment, I'm working on a systematic review where we're looking at all the pediatric guidelines to identify which guidelines use race as a diagnostic factor, or at least a factor for administering care. And we will be surprised that there are many guidelines that use race not as a identifier of health inequity, but to suggest you should do one thing over another based on someone's racial category. It's those things that sit there. And so while we may not be benefiting from it, there's a system that is benefiting from it, and it will continue to do so unless we walk in the opposite direction of that conveyor belt and say, you know what, I'm not getting on there. And so everyone can get access to this benefit. And that's uncomfortable for some because they say, well, are you saying I have to give something up? And I would argue that, yeah, that if there is someone who is not benefiting from the things that we are benefiting from, and let's be clear, we're all benefiting in some, I carry an immense amount of privilege, but I have committed myself to make sure that in those privileges that I carry, that they're leveraged and used for folks who don't carry the same privilege. Whether that's folks who are undocumented, whether that's folks who aren't able to access the education system, whether that's folks who aren't able to access basic education. I give my class for free. And I tell community, you can come to my class and I want you to sit in. Right? It may be small, but it's those things that we start checking our privileges to identify ways to better the outcomes for the historically marginalized folks.
And I will say, in listening to your podcast and reading, I think, Shaquita, you said it best when you said, we all have to educate ourselves. And I've gone down that journey now because I realize how little I know. And something as simple, it seems simple now, but the difference in the definitions of racism versus prejudice, which I did not know until I heard your podcast, that racism is prejudice plus power. That you have to have some sort of power over another group in some way, shape, or form to be racist. Everybody has a level of prejudice at some point or another. Human beings do. But to be racist, there has to be a power element involved there. And that's still involved in medicine as well, right?
That's still involved in medicine. And I'm like shaking my hands in joy that like the podcast is working. Folks are listening. They can reiterate the definitions. And you're right. It is about power, because someone oftentimes give me, my wife is Black, she's a physician. And they say, well, Edwin, your wife can be racist towards a white patient because she has power. And I say, oh, I see what you're trying to do here. You're trying to set a trap up. But no, I thought about that already. And the reality is we're talking about different types of power, right? Economic power, socioeconomic status, and that power is very different than having the power of an institution to support a racial identity. So my wife may carry a prejudice of classism if she were to harm someone who happens to be white. But her Blackness isn't the reason that harm is being created. It's because of her economic status, her privilege of education as a physician, a licensed physician, right? Those are the power axis that we're talking about. But people start to conflate them and say, oh, well, I've gone to Atlanta and Black people hate me because I'm white. And I'm like, okay, that's not racism. Like, you chose to go to Atlanta and you get to leave Atlanta. There's people who live in those neighborhoods who don't get the choice to do any of those things. And so power is an incredibly important component to the definition, but it also informs how we describe other forms of oppression, right? From patriarchy and sexism to transphobia to homophobia. Those things are in cissexism, which is a conversation that I think folks should be digging into and looking into as well, so that they can get a better understanding of that. But power is a key component here. And when we can understand where the power lies, we have a better understanding of how we can start deconstructing the harm that's being caused. Shaq, what do you guys say? I know you were thinking.
Yeah, I was just thinking how important it is to have a shared dialogue about all of this. If we are all talking with different words that have different meanings, then we're not moving forward the conversation, and we're not moving forward our community knowledge around this. So I do think it's important to really understand what racism is. And then you can articulate to somebody who's struggling to understand why this definition is important, how this moves these thought processes forward. And ultimately, it means that we will be able to find solutions if we're all speaking to each other in the same language. And I mean that literally, but I also mean that in the way that our human nature is to evolve our philosophy over time. And what, again, to fall back on the equality versus equity, we see that example in that our human intellect and the way we are thinking and cogitating on this is that we are evolving the way we think about racism and how we see it, how we define it, and how we understand it. And that helps us find solutions towards eliminating it.
And Tony,
the other thing I was going to say,
I was
going to say also the reverse racism thing, but you covered it so much more articulately.
No, that's great. Yeah, if you think of reverse racism, I'd say write it down, really think about it, and try to understand where power lies. I mean, in the term itself, to be reverse racist means that it comes from an original source of racism, right? That means there's power in the original source. And we can get deep into that. I'm not actually going to get into it. I'm like, that's a whole course. But the other point I wanted to make was on, our language. Yeah, our language. Yeah. So I believe it's Webster's dictionary, is now going to be changing the definition of racism because they have been pushed and were asked to actually have it reflect what racism actually is, which is a apparatus of power for the purposes of creating privilege for a certain racial group. And they've agreed to that. They haven't finalized the language yet, but they will be changing the definition of racism, because currently the way it's defined is that racism is the belief of an individual to be superior over another based on race, which doesn't really talk about power. It's about belief. And so, yeah, in that case, anyone can be a racist. But I would argue that it doesn't actually have the same effects when one group is doing it and the other group doing it doesn't have any power at all. And I say that, right, because some people say, well, what power do I actually have, Edwin? I don't know what you're talking about. If I say something silly about racism, I get fired. Isn't that racism because I'm a white person for getting fired for saying something silly? And when we talk about power of a system to uphold and uplift a racial group, we're talking about looking at the bank loans that historically and disproportionately don't get lent to Black and brown communities. We're talking about looking at the underfunding of education in poorer communities. We're talking about the inherent voter oppression that exists in our country by law, which is disproportionately affecting Black and brown communities. Those things aren't happening to white communities. It's not that I want them to happen to white communities. I just want us to be clear that when we talk about power and oppression, that has been disproportionate in one or a few racial groups. And folks are just saying, can you please just give us equity? Like Dr. Bell said, just give us equity. Let's have the equity so we can be in the conversation to get the health and the care that we deserve. But at the moment, we're just not there. It's ingrained in our medical education.
I think the other piece of equity that's really important that we fall into as hospital systems, as medical systems, is we feel like there is one treatment and that treatment is going to reach everyone. So Back to Sleep campaign is a really good example. We decided that universally everybody has to put their babies on their back. And I'm not saying don't report me to the Board of Pediatrics. I'm not saying don't put your baby on their back. I am saying that intervention did not improve infant mortality for Black and Native American babies. So that's an example. We equally applied this policy, we equally applied this intervention, and we found that there was an inequitable difference in the rates of death in these infants. So it's not that putting babies on their back is bad, it's that putting babies on their back alone did not counter the impacts of racism on those communities and didn't address it.
Shaquita, I'm a little embarrassed to admit, I didn't know that. So in the Black and brown communities, the minority communities, the Back to Sleep campaign didn't have an effect in terms of SIDS rates.
Correct. And in fact, the latest data out on Black infants is that we have worsened. The outcomes for infant mortality have worsened.
It brings up even more questions.
Yes, like shelter in place. Why don't you just put your baby on their back in that handy dandy crib that you have, right? Yeah, it is these blanket statements that nobody really thinks about. How does that apply to individuals in different communities, and what does that look like?
And that's a unique nuance between the biological element of race and then the cultural understanding of race, so that when we provide clinical guidelines, they need to be responsive to the culture of different communities. Because someone may be hearing this and say, but you told me that race doesn't matter. So how is it that this universal guideline didn't positively affect everyone if race wasn't an issue? Well, because we're talking about cultural differences and how people engage in the spaces they're in, the communities they're in, right? Those are the things we have to consider here. And again, we're not talking about the biology of individuals. We're talking about the care and how, think about COVID. We have here in King County elected officials that get in front of public television, announce what is happening, providing updates, but they're only providing it in English. And so they're saying, oh, but these communities are getting higher rates of COVID and the higher rates of mortality. Yeah, they're getting the updated data 2 to 4 days behind when everyone else is getting it, because we're dependent on nonprofit organizations to write up the translation to then share the information with the communities. So if we're not responsive to it, then yeah, these communities are going to be detrimentally harmed. But again, it's not because of the melanin of their skin.
Such a good point. Thank you, Edwin. It is really important to remember that race is a social construct, but in a way, culture is as well. But culture is how people self identify and how they live their life. And so impacts to different communities or the way different communities practice are usually related more to culture.
So, I mean, it brings up a question, at least in my mind, of okay, if I'm going to help improve this process, the public health process, and as a physician, I want to help. I know I have to educate myself and read. I've gone down that road, like so many others. I mean, our division now has a diversity and inclusion. What are they called? Book clubs, which I'm not crazy about book clubs, but we have that, and we sit and we talk about it and discuss it, and they're uncomfortable conversations, but we're having them. But then what is the is there a next step that we have to do now or think about? Or is it once we have educated ourselves, then naturally research will begin occurring or happening that helps address those cultural differences, not just in all communities? Am I right, or am I being too optimistic, or what am I doing?
Well, I think it's important. I think the piece that is also important is if you want to address a concern in a community, you have to have the community at the table, right? Like for me, it wouldn't make sense for me to tell people on North in the North Seattle area a solution for their problems when I live in South Seattle. It doesn't make sense. I don't know what the trees look like over there. So it is, I think it's important to educate ourselves, but I think it's also important to include the people in which you're trying to impact. And if even better is to have them identify the problem for you and then you just help them fix it.
Yeah, I think Dr. Bell hit it on the head. Is as health professionals, as clinicians, you can actually make your job easier by including the community and saying, I'm doing this because I don't want to suggest that I'm the expert in these things. So let me bring you in so you can help inform how we can better provide care. And the beauty of it is that community, they want to do that. They want to get the better care. They just want to do it with folks who they know they can trust and will actually be receptive to the information they're saying, even if it is counter to what perhaps a guideline suggests. I'll give a quick example. I constantly think of different cultures that will come to the United States and we're talking about a nutrition plan for a particular patient and saying, oh, you have to eat these things. Well, without the cultural knowledge or understanding of that culture, you may not be aware that that community doesn't eat those things. And they probably never will because they don't know where to get those things. Because when we go to our local market, when we go to our local store, those things aren't being sold. But what we do eat are things that are reflective of our culture. And so in understanding culture, we can actually become much more precise and say, oh, thank you for sharing. My understanding is that these types of foods are available. Do you have access to these things? Oh, yes, I do. Great. Well, here's how I'd like you to make up a nutrition plan based on the food that is responsive to your culture, and let me know if this will work out. Right, that's a very different approach than a unilateral, well, this is how we do it. Here's a pamphlet, and here are the things that you should be eating. I know my grandmother would come back and she said, oh, the doctor said we need to eat this. And she's like, but I'm never going to buy that because it doesn't taste good, or that's not what we eat. And so it would be thrown out the window, right? It's in the, and some folks would say, oh, well, that's their fault. They should have been listening to the doctor. Or we can reframe it and say, maybe it's our fault because we're not being good teachers and listeners and contributors to the community. So I always, as an educator, I always think if the response I was expecting from a student isn't what I got, then that means there's something that I did to affect that response. So I need to change what I'm doing. And I think that's true for practicing medicine as well, is how do I adopt myself in a way, or adapt myself in a way that is responsive to get the results that not just I need, but that my patient needs.
That's everything I wanted to cover. Is there anything else you guys wanted to cover that we haven't talked about?
I'd be remiss if we didn't mention that we are in in the time of recording this, we are in the midst of probably one of the largest civil rights movements in the history of this world. And I would ask that the listeners really take the time to get an understanding of why this movement is occurring, why folks are so upset at the state-sanctioned violence that exists in predominantly Black and Brown and Indigenous communities, and how these things have been happening for generations. And for many, this may be the first time you're seeing it, and you may be even shocked. But in that shock, I would ask folks to step up and see what is occurring as something that's happening to your family, that it's affecting your freedoms and your civil rights when a young Black brother or sister is there on the ground with a knee to their neck, that actually is someone you should deeply care about and fight for, and taking that out into the community. And so Dr. Bell, Dr. Williams, my partner, and myself held the Healthcare Workers for Justice March with over 10,000 healthcare workers in the city of Seattle last Saturday. And the clear demand that we proposed to the elected officials was, you must make racism and police violence a public health emergency, and that it is a public health crisis. And I hope folks would sit with that and wrestle with it and try to get on board to say, actually, you're right. There's data that shows us there's people who are dying of smallpox at the same rate that people are dying at the hands of police violence. And we are willing to commit money to address smallpox, but we aren't committing money and resources in the medical field to address police violence. And we have to ask the question, why? Is it because it's disproportionately affecting only a certain group of people?
You can decide whether to put this in or not, Tony, but I would say bigotry wrapped in good morals and good beliefs is still bigotry. So if you have policies that are racist or that result in inequitable healthcare outcomes for patients, but you're doing it because it's the way we have done it, or it's what we should be doing, then I would counter that and say it's not what we should be doing, and we need to analyze that.
Well, I don't think there's a better way to end the discussion than those poignant statements. So I will just say thank you very much, Shaquita and Edwin, for being on the podcast, for having this discussion. I really appreciate your time and your expertise on this. I hope to have you back on. And Edwin, I'm real excited for the next episodes of your podcast. For those listening at home, again, it's the Praxis, Praxis, the Praxis. So thank you both.
Tony, thanks for having us.
Tony, did you want to say anything about resources or?
Oh, for those of you at home, if you go to the CME portion of the podcast, remember, CME is courtesy of the University of Pittsburgh. If you click on the questions, there's always a section for references. Shaquita and Edwin have been kind enough to share all of the resources and references from the University of Washington's website for the Center of Diversity, and I will put them all on the reference section. And if for some reason you can't log in, if you have any issues, email me. Everyone on the podcast should have my email, but if you don't, it's tony.tarchichi@chp.edu. I will send you the list, and I will put some of the ones that I like the best at the bottom of the podcast description under the CME portions, just so you know which ones I've gone through. I'd say a third of the ones that were sent, not the books. I haven't been able to read that quickly, but the newspaper articles and some others, and some of them I really enjoyed. So it'll all be there for you. All right. Thank you both again. I really appreciate it. This was great. Thank you for coming on.
Yeah, you're welcome.
Thanks, Tony. Thanks for reaching out.
I did send the Praxis on that list, so it's already embedded in there.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.